Welcome to Marney Reid Presents Connect to Develop, where we provide insight from healthcare leaders on the hottest topics and trends.
Hello, listeners. This is an exciting two-part series featuring Dr. Genghis Niver, double board certified orthopedic hand surgery specialist at Summit Health in Florham Park, New Jersey, his incredible physician assistant, Meagan, and Dana Jacoby, CEO and founder of Vector Medical Group. This series will discuss how and why to build out a highly optimized office-based procedure practice and the impact this practice model has on patient care, physician satisfaction, and it also reviews some of the cost reduction benefits. So without further ado, I'd like to introduce Dr. Niver, Meagan, and Dana.
Hi, this is Genghis Niver, and I'm really excited to be part of this podcast. I'm very excited to talking about how I was able to implement a very streamlined and efficient office practice, which is now actually translated into performing office-based procedures over the past few years. So thank you for having me.
Hi, my name's Meagan Lugo. I'm Dr. Niver's PA. I'm so excited to be here and to share on my insight on our office and surgeries and our structure that we've developed together over the past few years together.
Hi, Marnie. It's great to be here. I'm really excited about having this conversation with you, and I'm looking forward to really talking about things that are front and center in the MSK and orthopedic space right now.
Dr. Niver, to create a frame of reference for our listeners, can you tell us about the subspecialized orthopedic hand surgery practice you built over the last 11 years?
So essentially, my practice that I've had since I finished my fellowship is the same practice that I'm currently in for the past 11 years, which is a private multi-specialty group that used to be the largest physician-owned multi-specialty group in the country, which is no longer physician-owned and still very private, where we don't have any academic ties or any ability to work with residents or teaching opportunities.
But I understand that you still do a lot of teaching, so we appreciate all of the ways that you contribute to your individual societies as well as to Academy. So for the last decade plus, you've continuously reviewed and refined your practice from an efficiency standpoint, but with a fine focus on that patient experience and looking at the overall cost of care to the system and the patients you serve. Can you share what that process looks like and your advice to our listeners, both surgeons and their support staff, who may want to start building or optimizing a high-volume office-based procedure practice?
Well, my ideas for this really started when I was a fellow, and the popularization of local wide-awake hand surgery was created and kind of pushed through our hand society and orthopedic society to the hand surgeons. Once I started to see the value in being able to do procedures awake, reducing costs to the patient from the anesthesia perspective, as well as of the ability to not have to necessarily do procedures at the hospital or surgery center, you can start to transition many of the procedures into the office for many reasons, having benefits. And that type of ability for my practice to change and vary came because of maintaining an open mind. I think that maintaining an open mind is not just for me, but it's also for the administrators. It's for some of the staff to realize that there are ways to optimize things for the patient, optimize workflow, improve the efficiency of a practice so that the patients have a lower cost of care that's required from them, and the insurance companies benefit from that as well as, our practice utilizing less resources in a type of practice that I have right now.
There's so much talk these days about reducing burnout and the impact, especially from what happens during patient care, during and still pulling out of, that COVID era. Can you talk about how creating something like this, which to the benefits you've listed off of, reducing costs to the patients, to the overall health system, and, just even in kind of trimming up some of the ways that you go about practice. Have you noticed, or do you think that creating something like this high volume optimized office-based procedure practice has any kind of impact on physician burnout?
Absolutely. For me, the thing that causes me to have most burnout is hours spent being inefficient at the workplace, whether that be in the operating room or in the office. What I don't want is downtime during work. While I'm there, I want to put in a hard day's work. I want to be efficient. I want to maximize the number of patients that I see in a healthy, safe manner. And the ability for me to start to improve my workplace environment with regards to the efficiency that I have allows me to have a happier workplace setting, leading to less burnout, and scheduling certain days of the week for different types of options, such as, patients in the office versus when to do procedures in the surgery center or office. Picking those selective days has made a huge difference on my burnout. The final thing I'd mention about the burnout is getting the right staff around you to help you in this process of efficiency. And, scribes, medical scribes, mid-level providers, nursing staff, even front desk staff who know workflow, who understand the conditions that I treat. All of these things kind of improve my efficiency and as a whole result, improve my ability to not have a burnout.
Well, I've had the honor of speaking with several people on your support team, and everyone sounds super excited to be there, and like they've been able to be a true part of building what you have. So true testament to you for being able to build that team around you. So can you walk us through, to what you just alluded to, the rationale for scheduling your week and why you have your clinic days, ASC, and office-based procedures on those specific days of the week?
Absolutely. The thing that I want to start with is the Monday, which I feel is very important for a hand surgeon to see patients to capture all of the weekend injuries that occurred. So every urgent care that sees a patient on a Friday, Saturday, or Sunday will always say, follow up next week with a hand surgeon. And I want to capture those patients with acute injuries, fractures, tendon lacerations, nerve lacerations, etc. So I feel that a Monday should always be dedicated to seeing patients from the weekend. Creating specific slots. What I'll always do is at the end of my day, I'll have frozen slots that as I get a text message or an email from a weekend, during the weekend from a physical therapist that I may know, or a colleague who's another practice saying that their child got injured or their neighbor got injured. I want to be able to see those patients and not have to squeeze them necessarily in, but have dedicated frozen slots that I can see them at the end of the Monday. And that's really important, actually, that I do that on all of my office days, because constantly I'll be getting messages from people asking about a friend that has an injury. I feel that a Tuesday should also be dedicated to the office, because as a Monday gets full and my schedule gets full, the patient overflow from the weekend injuries end up on a Tuesday. And it actually turns out that sometimes I see more fractures and more acute injuries on a Tuesday than I do on a Monday. So that's how I start my clinic days on Mondays and Tuesdays. My rationale in setting up my schedule was also to have 2 OR-based days per week. Wednesday is what I have, and Friday. The reason I have Friday is that it allows me to end early on certain days and start my weekend early. Or if I end early on a certain Friday, I can always add a case on at the hospital to follow if I have to. But at least on a Friday, I try to be in the operating room. Operating room days aren't as important for hand surgery necessarily as they are in other specialties like total joint replacements, where you want to have a Monday operative day so that there's not many patients to round on over the week and that they've already been successfully discharged. Given that my practice is outpatient, this doesn't have that kind of limitation, but I still try to have a Friday operative day. Wednesdays are also my operative day, and recently has been sometimes a hybrid of seeing patients in between doing procedures in the office and sometimes having time dedicated at the surgery center. The Thursday office day for me is typically a day in the office to capture anything that occurred during the week. And if I need to put them on the operative schedule, I have at least the Friday to do it, the day afterwards, or the week after on a Wednesday, to not make a patient wait more than a week to have surgery if it's something acute.
That absolutely makes sense and does sound like you've really refined it and put a lot of thought into that. We're going to speak with Meagan in a little coming up, but in our prep calls, you discussed that her role changed a little bit when the payment model changed. Can you discuss a little bit about what that change was, what prompted the change, and for those providers and even office managers out there, how you've optimized and iterated on this, even through a change in your employment model?
When I first joined my group, we were physician owned and collections based. So the physician assistant was somebody that we had to ultimately pay for. And when we paid for them, we would collect what they collected. And that would sometimes offset some of what you had to do in paying for their salary and their benefits, et cetera. What ends up happening, though, in that model for a hand surgeon is that my utilization of a PA is mainly office-based for my post-operative patients rather than billing for a first assist for my procedures, because most of my procedures don't necessarily allow for a first assist fee to be billed. And therefore, my benefit in having a physician assistant is to have her see all of my post-operative patients offloading my schedule, especially in patients that don't have any reimbursement and really have low level of follow-up necessary, either x-rays, wound evaluation, motion evaluation, et cetera. And so we were initially collections based. After private equity took us over in 2018, we became RVU based. And the rule that they put on us is that the collection of the PAs for their work volume was not something that we captured as physicians. So therefore, by meeting certain percentiles in RVU per month, you can have a physician assistant paid for by the group, subsidized by the group completely. And what happens in that model for me is that it is of my benefit to have as many new patients and follow-up patients on my schedule and post-operative patients on her schedule, especially because I'm not collecting anything that she does.
For the patients out there that, maybe have been seeing a provider for a while and things have changed, or are just wondering how providers schedule their clinics and, the role that everyone plays in your critical care component, just understand that at the end of the day, they do, have to answer to the boss and the higher ups. And it's great that you found a workaround, to keep the patients very engaged with your team and also your team to be highly optimized. So to continue along that thread, can you talk about the very specific roles that your nurses, your medical assistant, and your scribe play, enabling you to spend time with your patients and address all of their needs, but still run a highly efficient clinic day?
The medical assistant role for me is very important in the sense that they initially have the first face-to-face contact with the patient and calling their name at the waiting room to bring them into the office and draw them into their exam room. What I've actually had my medical assistant do is ask the patient what is bothering them, get the basic understanding if it's a chronic pain, acute injury, and the location of where it is to whether or not it warrants an x-ray. Obviously, there are times when the medical assistant may not be able to gauge whether a patient needs an x-ray, and she may ask me directly whether I should get one or not. But my goal is to always have the x-ray and imaging performed before I see the patient and before the patient is roomed into an exam room. The worst part would happen is if a patient is seen, then they need an x-ray, that exam room is taken up. That patient may not necessarily be there for 10 minutes while they're waiting for their x-ray to be done, and it doesn't allow for the next patient to be brought into an exam room. So the medical assistant's role is mainly in rooming patients, in addition to used to be dispensing DME for a patient, especially in a hand surgeon's practice where splints are often prescribed or required. Splints need to be sometimes made. We now have a dedicated DME specialist for that, which offloads the work requirement for the medical assistant. The nursing I have in the office with a great team of nurses that I work with who essentially answer clinical questions from a patient regarding their post-operative wound or not being able to initiate therapy somewhere or further questions on medication management. They're the first line of defense in answering that for the patient. If that becomes a little bit more difficult, challenging, or outside of their scope, that will be bumped up to the physician assistant who has been with me for 6 years. She understands how I think. She understands how I treat my patients. She understands the disease processes, who can answer most questions. If there's a time where she can't answer that, she will ask me, and I will either call the patient or have them come in for a follow-up or a visit to evaluate them in person. But the nursing staff is very important there for that reason, is that they're able to answer most clinical questions from the patients directly. The nursing staff in the office is also responsible for sometimes adjusting an MRI order or changing some of the orders that have been put in or refilling a medication prescription. That's something that they're able to do as well. And the final component that I would say in my practice that has significantly optimized and has been a game changer in my practice and revolutionary is having a medical scribe. Given the volume of patients that I see, which on average is anywhere between 45 and 55 patients per day, documentation becomes difficult. Keeping up with documentation is difficult. Closing out a note, making sure that orders are put in. The medical scribe, their number one thing that they're there for is to document the visit, but they also are very important as being an accessory to ordering the imaging that's appropriate, ordering the medications that are necessary, and ordering any other, referrals that are necessary for EMGs or neurologist appointments or rheumatologist appointment. And therefore, when they place that order, it always shows up as a task for me to sign. Obviously, I will only sign it if it's completely correct, but the medical scribes have been trained on how to put in the correct orders, especially as I talk to my patient. The final thing for the medical scribe for me, though, is that, I no longer have to do 60 notes on a Sunday night from 6 p.m. to 9 p.m. My notes are almost always done the day I finish clinic. I sign them all as they go along. When I have some downtime in the office, I will sign notes, but they're able to keep up with my practice, further allowing me to see more patients in a day. Insurance companies are starting to be a little bit more critical of the documentation in allowing for billing to occur. The medical scribe will use the correct terminology, capture appropriate diagnoses, and then also discuss, medical management of certain things that allow me to further, code appropriately, or occasionally on some occasions upcode for what was done, because they're able to document it so precisely.
I am sure that your family greatly appreciates the scribe as well, so that they have you on Sunday. And for those that are collections based and RVU based, I'm sure it really helps to, have them for that documentation. And, to continue to unpack that a little bit, it was interesting because on the prep call I had with your scribe, who you said the current one is the best that you've had, currently medical student about to, head into residency and whatnot. So obviously already on the track to really understand what's going on. For those of you out there listening and wondering, how to properly screen for a scribe, one of the things that I think helps with the current one is this current scribe is able to type without looking at a computer. And so he has actively been watching what you're doing and pairing, the part of the body or the words that you're saying along with, places that you're pointing to and everything. And so that's really helped him get up and running with a lot of the terminology that you use or being able to document. So that's a little tip out there for people looking to come on board with a scribe. So there are very specific roles that specifically your nurses and PA play during the office-based procedure days. Can you walk through what that flow looks like for our listeners?
So my office-based procedure day is typically on a Wednesday. If I have surgeries in the surgery center, the office-based procedures follow thereafter. I'm very lucky to have my surgery center in the same building as my office, so I can quickly run down and start my in-office-based procedures. Days where I'm not having time in the surgery center, it starts at 8 a.m., where the first patient is booked for an 8 o'clock slot, and it's a 30-minute slot for their procedure. I ask that every patient get there at least 30 minutes ahead of time, so that I'm able to inject the anesthetic, which involves lidocaine and epinephrine. And it takes about 25 minutes for the epinephrine to work to create minimal bleeding during the actual procedure. And so as the patient arrives, the medical assistant brings the patient back, checks their vital signs, provides their consent form for me to have them sign and me sign in front of them. I see the patient, I discuss the consent briefly, I mark their hand, I explain what I'm going to be doing as I inject them, what I will be doing during the procedure, and the post-operative care involved. I inject their hand, I leave the room, I have time to either see more patients, which recently I have been booking a slot or two after the injection to book a procedure, or catch up on documentation, anything that I have to do clerically. Afterwards, about 30 minutes later, our nurse brings the patient back to the procedure room, preps their hand, has already laid out the sterile table setup, and essentially the physician assistant comes in to drape the patient. My goal in the future is to minimize the amount of draping I use, but currently I have a standard type of hand drape that I think will provide a decent enough sterile field while also shielding the patient from seeing anything that I'm actually doing for their own benefit as well as for their own safety. And then the physician assistant, when she's prepped completely and draped the patient, I show up, I prep my hands, I put on my gloves, and I perform the procedure with the physician assistant assisting me during the entire procedure. Once I finish the procedure, the physician assistant sutures the wound, places the appropriate dressing on. I go around the drape to speak to the patient directly, face to face, and explain the postoperative care again. That postoperative care again is finally reiterated by the medical assistant upon departure, where they go to their original exam room. So I have 3 exam rooms set up for every office day. I also have 3 exam rooms set up for every office-based procedure day. Therefore, one patient will be ready to inject, one patient will be returning back, and then one extra room if somebody's either there early or running late.
That makes sense, especially with the amount of rooms that you would need. With the ever increasing pressures of declining reimbursement, with the pre-authorization hurdles, RVU requirements that you were alluding to, what should patients know about care delivery and optimization so they can better understand the world of physician practices as they function today?
I really think that patients oftentimes don't necessarily understand what's involved in the limitations and constraints that are put on physicians for appropriate reimbursement from the insurance companies. And the way it really starts is that the insurance company wants to see cost-saving procedures, cost-saving measures done so that their added cost is not increased. And by doing in-office procedures, there is no facility fee charged to the patient because it's a non-facility type of environment. And certain procedures, such as trigger finger, have a higher reimbursement for the physician for Medicare patients than facility-based procedure like trigger finger. So if a trigger finger is done in the office, it actually reimburses the physician more than it would be done in the surgery center. That should be an incentive to the physician. The cost savings to the patient should be an incentive to the physician. And the turnaround time that is done in the office allows me to have at least 2 to 3 procedures done per hour, which is much faster turnaround than any surgery center or especially any main hospital.
What do you feel like is the biggest reason why the way that patient care is provided and the changes is occurring?
I'd say one of the biggest changes that I've seen since I was a medical student to now is the utilization of mid-level providers, whether it be nurse practitioner or physician assistant. The fact that I have a physician assistant allows me to see a different amount of patients in a day that are reimbursed type of patients, that are new patients or follow-ups, and allows me to see, 20 to 25 new patients per day so that I can book more surgeries based on their acuity of their injury. In the past, I don't think that was the case with mid-level providers. The fact that they are seen almost in every type of practice and every specialty is definitely new to the patient. But the patient should understand that a lot of the postoperative care required does not require a significant amount of decision-making to a person that can be easily trained into the practice. And so my physician assistant, who's been with me for 6 years, understands my postoperative protocol, understands what I do during the procedure, and understands that postoperative care involved so that she can answer almost all questions that were asked of her from the patient. And that allows me to not have the postoperative patient seen in my office schedule, taking away from slots from a new patient that could potentially be surgical. And so I don't think that patients have understood that's one of the changes that has happened over the last 10 to 15 years, allowing for a different type of flow in the office.
Meagan, you've been part of this process from the start, first working with other providers and then solely with Dr. Niver. Can you share the main differences in how Dr. Niver and you approach your days with scheduling and timing, and what's unique about your workflow?
Yes, definitely. So I've worked with Dr. Niver now for about 5 years, and we've worked together to find the best way to optimize our time and efficiency in the office. So we are in the office together Mondays, Tuesdays, and Thursdays. Dr. Niver has his own panel, which is a combination of new patients and follow-up patients. And then I have a schedule that mimics essentially the same time as him, but mostly with post-ops and then any overflow patients that he may need me to see. So when he's in the office seeing new patients follow-ups, I have my own schedule. On average, about 15, I would say up to 25 patients a day, all follow-ups from surgery. And in the hand world, that's a big deal. So other joint surgeons, sports surgeons may not have 25 post-ops in a day, but we're doing so many cases on our operative days that there's a lot of people to see in the post-operative period. So this is essentially up to 25 patients a day that would be on his schedule if I wasn't doing this. And that allows that freedom in his schedule to see 25 more patients, that new patients' office visits that would have been taken up his time in that time. And the reason that we try to be in the office together is that a lot of these surgery patients, they're happy to see me. I kind of build a good relationship with them, but a lot of them do want to see their surgeon and feel that that's important. So I'm able to kind of flag him down after I've already taken care of everything with them, know exactly what they want to see him for or talk to him about, and then I'm able to get him and bring him in so that they kind of have that satisfaction of knowing their surgeon came in as well.
What is the flow of the rest of the support, team as all roads lead to the surgeon? Do they come to you first? Do they go straight to Dr. Niver? Walk us through that.
Definitely. That's a good question. So Dr. Niver, like I said, is seeing his own patients, and that's another thing I should touch upon. So if I have gaps in my schedule, I am going in first to these new patients who are coming in and seeing them, figuring out what they're here for, trying to figure out their diagnosis and treatment plan, to then go to Dr. Niver and explain to him what he's going in for, what he's walking into, to give him a better idea. The other thing on the patients I'm not able to go and see, the medical assistant, the scribe, they're kind of prepping in advance. The scribe will do prep the day or two before, look if the EMG results, MRI results are there, and have those all ready to go with those results. And then the MA, if she sees like, hey, this patient's coming in for hand pain and wrist pain, not really sure what type of x-ray to get or imaging or workup to start, she'll come to me and say, hey, can you just look at this? What do you think I should have done before Dr. Niver goes in and see the patient? So that way, when he goes in, he has all of the diagnostics he needs to start his visit and get that done in a timely fashion.
Work with other hand specialist providers. What would you say are the biggest differences in the way that you and Dr. Niver and his team have set up this flow to enable that high efficiency that other providers may not have?
I think one of the biggest things is that I see the post-ops for their entire 3-month, 90-day period. I do know even some hand surgeons still prefer to see their post-ops after the first visit for whatever reason, whether that's for the continuity of care or just the kind of arrangement they have with their own PA. But I think that's one of the biggest things that makes it most effective, is that anybody in their 90-day post-op period is seeing me and not needing to wait to be either squeezed into his schedule or taking up time on his schedule that he needs for other people.
Talk about the efficiency that a really good scribe creates for you personally.
A good scribe, for me personally, the biggest thing is the prep. So if I'm going in to see a new patient and the scribe has done their job ahead of time, I can look in and kind of see anything that they've put in already, what imaging results have maybe been done already, and everything just in that chart ready to go just makes it easier to look in and see that. Yeah, definitely total team approach in the office patients as well as those procedures. And I think that's a big thing. I think some people kind of see like, hey, if Meagan doesn't have her own post-op patients, what's the point of her being in the office and helping? But I think the impact that it makes on his day and just how I can speed up the process along with our other team members makes a big difference. And even with our office procedures, we have a whole team available with us for that. So somebody takes the patient in, usually the medical assistant. I have the consents that the patient has to sign to consent for surgery filled out ahead of time. So Dr. Niver is able to walk in, consent the patient, inject the patient with that local medication. They get their vitals taken, and then our nurse is ready to go. Bring that patient in our procedure room, get them prepped and ready for surgery. I walk in, I complete the prep and scrub myself in, put down the drapes, get his whole sterile field ready to go. And then he walks in and we do the procedure. And we do 7 to 8 of those, I think, on Wednesdays.
Dana, as someone who gets hired by health systems and mid-sized to large practices to create and execute various growth strategies to help optimize providers, can you talk about what you're seeing in healthcare, specifically to orthopedic practices, and why optimizing patient care pathways and efficiencies is so critical?
Absolutely. It's been interesting, Marnie. Efficiencies have always been important, right? And care pathways, we've heard about value-based care and care pathway management for years and years. I think the reality is over the last 5 years, between COVID and all the mergers happening in the orthopedic space, the market has been so fast that some folks, I think, were glossing over things like value-based care and critical care pathways and efficiencies. As things have, and I'm not going to say slowed because that's the wrong word, but as things have tempered, there's just a lot more focus on operational excellence and efficiency models. And so we're really watching a lot of groups, one, get to a scale where they can start to invest in these things. Two, things like direct to employer contracting and really maximizing clinical support teams is becoming really critical. We're hearing operational excellence seems to be the words of the year this year in 2024, which should have, I'm always like, when did we get away from that? Because wasn't that always important? But it really
exactly.
It really is critical right now. And we're finding a lot of C-suite executives looking downstream into building care teams, not just having Dr. A, Dr. B, Dr. C, and Dr. D doing 4 totally different things. When there were so many mergers happening, Marnie, whether it was mergers with hospitals or private equity, and that market is still very much happening. But when all of that was happening, everybody was so busy getting married, they weren't building the house together, right? And now it's like, wait a minute, we're married now. It's time to really build a house that's going to be sustainable and thrive during good and bad times. So it's a different approach. It's a complementary approach, I should say, to the way we've been in the last few years.
Thank you, Dr. Niver, Meagan, Dana, for this conversation. We leave this 2-part series now with the second one discussing how a highly optimized office-based procedure practice for hand surgery specialists enhances the patient experience and lowers the overall cost of care. Thank you so much, everyone, and we look forward to part 2.
Thank you so much for having us today, and I'm really looking forward to part 2 as well.
Thank you for having me and allowing me to join in on this podcast. Looking forward to talking to you further in part 2.
That's great, Marnie. Thanks so much for having me, and I hope that your listeners found this to be very beneficial.
Thanks for listening to Connect to Develop. You can find more interviews and Marnie's Minutes on my YouTube channel at Marney Reid Presents.